Well, good afternoon, everybody, and thank you for joining us. Today is August 7th, 2020. It's 1 o'clock in the afternoon, and if you just happen to arrive here, you're at the CAF COVID Weekly Roundup. This is a weekly webinar series that we've been doing to try to capture some of the most recent AFLs and updates, as well as talk to you about some preparedness activities during COVID. And we've talked about a number of things as how we prepare and plan for concurrent disasters. And so we have a very special guest with us today, Mark Bentham from the Southern California Earthquake Center at USC. He's got his full title, which is too long for me to actually put on the title slide here, but he's got his own presentation. We're going to go through that as well. But we've got one big AFL that was updated last week. We talked about it some on the previous week's webinars, but I just want to go over because they did change some of the language, and we're going to go over that in detail here in a second. So that is AFL 2053. We discussed this on the webinar last Friday, and maybe an hour or two after the webinar, they released a revision, and we'll go over the revision here in a second. And it added language on the antigen testing, and it defers final guidance. And we'll talk about, kind of the conflicts in national guidance that they've tied our ability to use these devices to. We'll cover that. And I wanted to answer, before we get started, I want to answer one question because I've gotten a lot of emails in regards to this. So yesterday, Heidi Steinecker on the CDPH HIAI call received a question about the testing for Medicare residents. And we, CAF, understands that we think she was conflating the testing of staff versus the testing of residents. And the answer that she gave, I think she was mistaken. So as we understand it, the payment for testing of residents on Medicare is supposed to be in the bundle for Medicare. And so that means we don't have the ability to charge for those tests, Medicare, for the residents. So while I think that she was genuine and she was talking about the emergency regulations, those relate back to the staff testing and not the resident testing. So I wanted to just clear that up. It doesn't mean that this is a final resolution. We know that nationally we're really pushing to have the testing not included in the bundle, simply because those weren't a part of the negotiated services when the Medicare bundle was determined, and those are pretty outsized costs when you factor in how often we have to do it. So there are still advocacy being done on a national level to make sure that Medicare has the ability to pay for that, but as it stands now, it does not. It's included in the bundled service. I wanted to make that clear. That's how we understand it now. Doesn't mean it's going to stay that way, but it's certainly one of the things that we're trying to work on. So, got that out of the way. Let's talk about this AFL 2053 for a second here. If I can get my slides to advance. Oh, there we go. All right. I think I maybe even went one too far. All right. There we go. Sorry, forgive me for the technical difficulties. All right, so in the language from CDPH in the AFL, they changed the language to remove the 95% specificity language, and they added in language here that says the test used should be an authorized nucleic acid or antigen detection assay. And then those two devices or two types of tests are defined on the CDC's website under viral testing. So this is a big change because they took out that metric that said which would essentially made us only use PCR testing. So that's good. That's good news that they've adopted this ability to go to that. But it does essentially point us to the CDC direction. So the test used should be, you know, what is recommended for testing in nursing homes by CDC. And I put these two links here because that's where you can find the information from the CDC. And actually that first link is kind of the all of long-term care page. And then from that page, there are tons and tons and tons of links. I know I talked about this webpage last week on the website, and I gave it a little props, but after looking for the testing of healthcare personnel, to be able to find that readily was really difficult. So if you guys are looking for that, these are the specific websites. And let's talk about the conflicts within the CDC guidance. So on that first link, the long-term care page, it says create a plan for testing residents. And then it refers to viral testing. And we know in another portion of that CDC, it describes viral testing as both PCR and antigen testing, and it does not tie a percentage, meaning it doesn't say it must be 95%. And I'll show you what that looks like because there's still language from CMS that says that in a second. But so we know this antigen test is now considered a part of the viral testing that CDC is considering. The only language I could find in there that referred to the PCR testing was access to tests capable of detecting the virus, ergo polymerase chain reaction or PCR testing. It does not, it removed the language that said 95%. So when it says access to tests capable of detecting the virus, you know, PCR test is an example of that, but it's not the only type of test that's able to detect a virus. So I think, you know, there's some real confusion in the language here that essentially says CDC leads you to believe that we could use these antigen tests. And we just wish CDPH was a little more clear in what they're going to do, but I'll show you the language as it goes on to talk about testing of healthcare workers. Now, on that second link, there's a spot where it says testing of asymptomatic healthcare workers. So we're just talking in a surveillance setting when you have no known exposures. Could we use this antigen testing for our surveillance testing? And it says currently testing asymptomatic healthcare professionals without known suspected exposure is recommended for healthcare workers working in nursing homes as part of the recommended reopening process. And then in this situation, initial viral testing of all healthcare professionals in nursing homes, along with weekly viral testing. Notice it does not recommend or say PCR testing. It's using the term viral testing, which is otherwise defined in the CDC's language as both the PCR and the antigen test. So state and local officials may adjust the recommendation for testing, which we know they do. And if you're in Los Angeles County and you listen to CDPH talk about there's no surveillance testing requirements for residents, you know that in counties it's definitely different. All I'm saying is that CDPH tied this to the CDC recommendations, and after reviewing the recommendations ad nauseum, I cannot see anything within the CDC recommendations that would preclude us from being able to use these tests. And I know if I read that, we assume that was CDPH's goal was to tie it to the CDC, but we would like a little more concrete information on the antigen testing. As it stands now, I think the CDC is okay with the use of these. We certainly know that in other states, they're using it not only for surveillance testing, but for diagnostic testing as well. Here's the one caveat. When we talk to CDPH and we ask them about the antigen testing, and they redid or revised the AFL to talk about this, the AFL, they removed that language. But when we verbally talked to them, they said as soon as the CDC and CMS changed their language to accept the PCR test. So I think the CDC, there's language within it that would allow us to be able to use these devices. The problem is in the AFL, it does not tie the testing to the CMS recommendations. But when we talked to them on the phone, they said it has to be okayed by CMS and CDC. And so I think we've accomplished the CDC side. It's the CMS side that we have questions about. So on the QSO that CMS sent out, it has this specific language in that and for testing that they expect the facilities to do. Arrangement with laboratories to process tests, and the test should be PCR tests with that greater than 95% sensitivity and greater than 90% specificity. So the last remaining kind of language that's holding us up is the CMS language. Now, I realize not everybody has these antigen devices, and we don't know when everybody's going to get them, but for those that are doing it, I know this is really important because it could meet a need immediately with the testing. So we're really trying to get them to hone in on a concrete decision for the state. The crazy thing is if you read that CMS QSO, there are many other metrics that CMS wants the states to meet and wants the facilities to meet that are impossible to meet. Things like 48-hour turnaround time that we know we're not getting, things like weekly testing of all staff, that's in that recommendation as well. So we know that the state is not essentially requiring the facilities to fill all of those metrics just because we can't, and they realize that. So is it possible that knowing we cannot meet this, the time frame requirements set out in the bullet point right before this bullet point on the QSO, could we use the antigen testing to be able to meet those goals? And when we get information, we will pass that along. But my concern is in the AFL, it does not tie this to the CMS requirement. It only ties it to the CDC requirement, which appears to allow it. So it's still up in the air, sad to say, but I think we're closer to seeing approval of use of these. In what manner, I'm not sure. I would find it hard to believe that we would use it for diagnostic purposes, but it's possible that may happen as well. So I just wanted to give you guys an update. It's not fully fleshed out, but based on Heidi's conversation on the call yesterday, my assumption is that something's going to come back out to further clarify whether the antigen tests can be used. So hopefully that explained it to you guys. I know you'll have questions. When we get to the end to the PowerPoint, we'll go over those questions. So, and with that, I want to get to our special guest speaker, Mark Bentham. Mark is the Director for Communication, Education, and Outreach at the Southern California Earthquake Center at USC. He's got other titles as well, or Executive Director of Earthquake Country Alliance. And so I want to extend a very warm welcome and thank you very much, Mark, for talking to us. I know we had an earthquake about a week and a half ago in the greater Los Angeles area, and it kind of got some folks' eyes open to what could possibly happen while we're also concurrently dealing with COVID. Mark, how are you doing today?
I'm doing well. Thank you, Jason.
Thanks for coming. Yeah.
You're welcome. Hello, everyone. I'm really happy to be here and just to share some basic information. A lot you probably already have heard before, maybe some resources you're not aware of, and talk about Shakeout this year, which you probably aren't thinking about yet, adding an earthquake to your planning and your response that you're already involved with. But it is really important to actually practice what to do when situations change. And so next, Jason, that's what I'm here to talk about. Jason mentioned the Earthquake Country Alliance. I want to highlight this is a statewide group that you all could be a part of. Go to earthquakecountry.org/alliance to sign up. And we have committees. We have a healthcare committee. We have other groups regionally too. And next, our webpage at earthquakecountry.org and terremotos.org in Spanish features the 7 steps to earthquake safety, documents, videos, and news and other Resources and next. The 7 steps to earthquake safety are really the key way that we organize the guidance and information, particularly for earthquakes. There's a lot of overlap with any disaster. But for example, for earthquakes, we highlight right away, secure those things around you that if they were to fall or fly across the space would cause injury, damage, issues that you don't want to have to deal with when you're dealing with everything else. And of course, this is important at home, in your workplace, in your facility, and not only for you, but for your other coworkers and your families and your patients and everyone. Of course, more things secured means less people that you have to treat because of injuries. And if you're in a facility that has, long-term care type facility or such, you don't want to cause injuries to your residents. And I'm not going to go through each of these in overview here, but you can go to earthquakecountry.org/7 steps. Next. However, we also are doing a webinar this year on each of these topics called the Safer at Home webinar series. So far, we've done step 1, and the recording of that is on the website here, earthquakecountry.org/safer at home. And you can watch that. We actually had live demonstrations about how to secure things with experts in doing those from the companies that sell those products. Our next webinar is going to be on August 19th, and we'll be announcing the registration for that on Monday. If you want to get on our email list, you go to earthquakecountry.org/alliance and click join the alliance. And if you do that before Monday, you'll definitely get the announcement of that. And plan to be safe is what you do before the earthquake to react safer when the earthquake happens, to respond immediately, and plan for your recovery. So it's all the things you do before the earthquake that determine really how things are going to go when the earthquake happens. And then we'll have other webinars coming up too. Now, one webinar that I really failed to include, and I should have, and I'm going to copy the link into the chat, I think, if I can do that, is a healthcare specific webinar that we've been doing each year because of Shakeout. It's a national webinar even, and this is called Earthquake Planning During COVID-19, Shakeout Earthquake Drills. And we do this in connection with Connect Consulting Services. And this is a lot about how you adapt your CMS requirements for emergency drills for Shakeout. And we'll be talking about some of the topics that we're talking about today too, or some of the ways that we're evolving Shakeout. So that link is in the chat if you'd like to sign up for that. Oh, and the important thing is that is August 12th at 10 a.m. So just next Wednesday. Okay, next please. And then the 7 steps also are in some booklets we have, and so you can download these too. And we do have these in English and Spanish and Chinese. Earthquakecountry.org/staying safe, very basic overview that you can download and email around. The great Shakeout earthquake drills are now what I'm going to really focus on. And of course, last year was record participation across the globe, across the country, and in California, and many other states and locations too. We're not expecting that this year because of COVID, but Shakeout is happening, and we're really encouraging people to think through how would you adapt an earthquake drill plan for the current situation, because while Shakeout normally happens on the 3rd Thursday of October this year, October 15th, and many people might do their drill in kind of this fun way we put it out a number of years ago at 10:15 a.m. on 10:15, and that varies from year to year. Earthquakes don't always happen on such a regular schedule, and when we want them and when we're planning for them, or when we're all together in any given year. And so by thinking about this year as, okay, we're not all together in their normal situations. We have, of course, students who are working from home and distance learning, and a lot of people working from home. So how do you coordinate that type of activity across an organization? And a lot of that, next please, is how we will be thinking about really continuing to encourage people practicing earthquake safety, and because it really can still happen, next, to start really shifting that culture about earthquakes, that yes, there's things that we need to deal with, of course, and we need to get better prepared. And overall, that leads us to increasing resilience. Next. And really, that it is really true that everyone can shake out in some way. Now, Jason, I know you're not doing this. I think it has some sort of animated thing on some of these slides. So
okay. I was like,
what? You're probably going, why is this going forward? But the idea is that in various settings, I think the lower right was a long-term care facility in many different places and in new ways. Now, really quickly, why do we say drop curve or hold on? Because things fall inside where we are, and especially off of buildings when you're long before the building itself collapses. And rarely does it actually collapse. You may have seen pictures of that. Usually those are like the pictures that get shown, but many buildings around those buildings we've seen in other countries and places are still standing. Some of them have had facades and bricks and other things that have fallen to the ground just outside the building, but they're still standing. So if people run outside, they're actually putting themselves at risk for that. And inside, there's usually a place you can get to provide additional shelter, like under something. So next, so what we say is you want to drop where you are, not running down the hallway to find some really good table that you can get under, because most likely you won't have time. You want to drop on your hands and knees. Next, you want to cover your head and neck with one arm and hand at least. And if there is something you can get under nearby, crawl underneath it. If not, you can get next to a wall, like away from glass or away from windows. And if necessary, next to something else that could provide sideways protection. And then hold on to your shelter until that shaking stops. And if you're not under something, just as shown in one of the pictures here, keep your head and neck covered with your arms and hands. Next. Now, some people can't do this. And it's not just people who are regularly, maybe someone who uses a wheelchair or walker or is not able to do this. It could be any of us on any given day if we sprain our ankle or break a leg or have some other situation where maybe medication that we're taking for something is making us more dizzy, or just something that you may not be able to react in the normal way. So we always can have this type of access functional need, as often we call this. And so it's important to know how to adapt that response. And also, so we've talked about showing kind of, if you're in a wheelchair, setting the brake or locking your wheels. Some walkers have that too. Sitting, bending over, covering your head and neck. If someone using a cane, keep that with you if possible, so you can help you get back up. But importantly, let others know around you what to do. And if you have residents or patients that are in these situations, practice with them. Make sure everybody knows that they should not be dragging the person in the wheelchair out of their chair and under the table, to the floor. That, of course, could cause greater injury. And it's also really important for, I know a lot of healthcare providers, your mission, who you are, you want to cover, use yourself as the shelter for people. And really, a lot of people say, while that's maybe your instinct, you want to make sure that you're okay and safe and able to help all the people that are going to be counting on you after the earthquake. So that goes back to making sure things aren't right over people that are going to fall, and that things are secured, so that you're worrying less about what might happen. Okay, and we have a number of these resources at earthquakecountry.org/disability. There, that link. Okay, next. And we also have guidance in the form of videos that you can watch. These are animated GIF video versions of these videos. They actually are longer, about a minute each, and you can view them on YouTube and download them at our website, shakeout.org/messaging. And Jason, I'm assuming you can email this around so that people can find these links.
Yeah, a copy of the slides is attached in the handouts here. So.
Perfect, perfect. And I just want to point out that we do have a version of this that's actually a longer, about 7 minutes, and it shows, it's the lower left video that shows something like 6 or 7 different alternative mobility assistance devices and the people who actually use those devices demonstrating how to protect themselves. Next. There's also a FEMA document we helped create, a poster that you can put up in a break room or somewhere. And if you call the FEMA warehouse, which is the number shown here, you can request copies to be sent to you. I think they'll send up to like 20 per request. This shows what to do. Now, I want to also briefly mention that, of course, there now is the California has the earthquake early warning system activated. And there are various apps you can get for your phone that may give you a few seconds of notice before earthquake shaking arrives. It detects the fault rupturing, it detects the earthquake starting and the waves starting to move away from that rupturing fault. It quickly determines that this is indeed going to be an earthquake that we need to let people know about, and it sends the signal. Now, next. You may not get the warning each time, and there are a couple different ways. You can make sure your phone has turned on to receive wireless emergency alerts. I mean, not turned on, but yes, it has to be on, but it has to be set to receive the wireless emergency alerts. And you can also download an app such as MyShake from the Apple or Android store. And you may have, if you're in Los Angeles City also has one. There's a couple that are coming on. And these will give you a certain amount of warning, not before the earthquake ever begins to move, but that once it's detected that the shaking is on its way. So it's if you're very close to where the earthquake was, it's not going to have time to calculate, determine, and get you that message before you feel it. You'll feel it before you get the alert. But if you're kind of in a sweet spot between that's a little bit further away and yet not far enough that it doesn't even matter, you'll get this message if the level of shaking is expected where you are to be a certain threshold. Next. And that, sorry, it's a little blurry. I need to get a new version. But basically what it's saying is that with the app, you'll get alerts for a lower level of shaking, what is called intensity 3. So they're looking at, okay, it's a certain type of earthquake, certain level, 4.5 or greater, and where you are, the shaking is expected to be something that you'd be more concerned about. Now, level 3 shaking, that's really low, and you're really not going to have much time to do anything because it's only going to shake for a few seconds. And it's a good opportunity to practice what you would do if it was a larger earthquake. And you should always react to these as if it could be really even larger. They're not telling you yet how big the shaking is going to be. So you're really not even going to know that it's this lower level shaking. You're just going to be getting notification. You may have had this last year when there were some large earthquakes and not gotten an alert. They actually lowered the threshold so that more people would get alerts. So you can find out all about this at earthquake.ca.gov. There are resources, or there are systems that will be coming available that are more of an installed system rather than just your phone, that a hospital or other location, schools and other places can have, to where it will tie into your PA system, or it will be some sort of box that will issue the alert and not be tied to your phone. So that's coming too. Next. So talking about earthquake drills, shakeout drills in 2020, it's a really key thing, as I mentioned, that, while there is that International Shakeout Day, October 15th, you really can choose dates and times for your drill that are even different each year, and it's a good practice. And whether you're planning to do an exercise or even just maybe you normally do a larger exercise, you don't have to necessarily do that this year unless you're really still having to meet your requirements for exercises. And there's some, you may be aware that if you're actually already activated, some of those CMS requirements may not be in place. But I still encourage you all to at least do the drop, cover, hold on aspect of a drill that if you normally may do a larger exercise, just so that new people get the opportunity to practice, new either staff or patients, residents, etc. In the new situation. People move around, people are in new settings. It's really important to practice that. And then you may have people who are not with you, that working from home or traveling or such. And so maybe there's a way that you can encourage that participation even if you're not all together. Next, please. So one way that you might even do something like a staff meeting is through video conferencing like this. People where everybody can see each other. Maybe you can do that drill and then talk about it afterwards. You know, people being prepared at home is really key so that they're able to, and willing to come to work sooner after the earthquake than if they're having to really deal with a lot of things. And of course, if in person for a drill, you still want to maintain kind of COVID guidance, protective space and equipment and masks. We are emphasizing that, you know, if a real earthquake, real large earthquake were to begin, your immediate danger is being, you know, having something fall on you or hit you or that type of protection. So people should really be focusing on protecting themselves from that potential danger, and maybe not necessarily be running to get their mask. Well, you're probably already wearing masks, but you know, making sure that the distance is in a real earthquake. But in a drill, you can plan for more of that. Next, please. We have a large amount of resources on the Shakeout website, some of which we are adapting for this year, and we're just also adding new ones to the web pages. And so you'll be seeing that come out. If you're registered for Shakeout, you'll be getting emails about that. Next, please. We do have a healthcare manual that is about to be uploaded, a new version that kind of talks about this as well. Actually, like over the weekend, we're going to be getting that on the website. So that's also a key resource for how you can plan it, everything from a very simple drop, cover, hold on drill to more of a functional exercise. And it ties into those CMS emergency preparedness rule guidelines. Next. And finally, I just want to mention again that we do have committees. We do have a healthcare committee. Jason's on our healthcare committee, and everyone's welcome to join. If you go to earthquakecountry.org/committees, you can see those and the email for how to be in touch. And you know, we meet like every 2 months for 1 hour and have discussions. You can help to develop content, resources, and activities that we put out through the Earthquake Country Alliance. Next. Finally, how to just kind of get directly in touch with us. Follow us on social media and through the websites, and then also just email info@shakeout.org or info@earthquakecountry.org. And one last thing, just again, plugging that link back to, thanks for, yeah, I guess I just sent it to the organizer, but the link to the webinar coming up on August 12th, and we'll kind of go a bit more deeper into the CMS aspects of Shakeout, and you're all welcome to attend.
Well, thank you, Mark. You got through that a lot faster than I thought you would get through that, but I'd like to make a couple comments. You know, I know folks, you know, situational awareness during a disaster sometimes is really hard to come by. And sometimes it comes from different sources. We've learned that through COVID right now. I mean, we have to pay attention to, you know, 8 or 9 different entities that we take guidance and recommendations from. So when it comes to maintaining situational awareness and all that is information about the current situation. If you're looking for a good website for situational awareness for both earthquakes and fires, believe it or not, the Office of Statewide Health Planning and Development, all of our lovely friends at OSHPD, have a fantastic mapping tool on their website that anybody can go to. And if you're, it has information on earthquakes and fires and wind speed and just, gosh, the whole kind of gamut. And I didn't put a link on this on the website, but if you go to OSHPD's website and you just put in emergency response operations in the search queue, it'll take you to the operations map, and this maps out every single skilled nursing facility and every single hospital in the state of California. And it maps them out in relation to wherever the current disaster is. So if it's an earthquake, it will list out where the shaking was and the severity. And if it's a fire, which we're in fire season, it also talks about where the fire is burning, what wind direction the fire is moving, a bunch of great information for us as providers when we need to make immediate decisions about the care that we provide. This is a great tool, and it's something that they launched during this COVID response, and we got firsthand a view of how it looks during the Apple fire in Riverside County. So I think it's, if you guys go there, you find that website, bookmark it, and just keep that in your queue as a possibility of maintaining situational awareness, for either earthquakes or fires. So thank you, Mark, for joining us. Luckily for us, we don't have a ton of new AFLs. I just want to briefly mention that we did have one AFL that was released this morning that looks like it was an update to the reporting requirements or the survey requirements, the online survey. And all the update was an update to how you register for that. So if you're looking at it, it's not that much different. And I didn't have time to add it into the slides here because it just came out this morning. But Courtney, maybe we can jump to some questions while we've got Mark on the phone, and we can go from there. I don't know if we have any questions today.
Absolutely, we have a handful. It looks like they're related to the LA County manual that came out. So Jason, I think this question would be for you. And
Sure.
I'll keep an eye and see if we get any earthquake related questions. So for our audience, if you have any questions, please go ahead and answer them into the question box now, and we'll get started. So our first question, has LA County DPH aligned its guidelines for discontinuation of transmission-based protocols with those of CDPH and CDC?
No, it doesn't. Oh, I was just going to say, no, it doesn't. But go ahead, finish the question.
Okay, its ACDC control manual calls for at least a 14-day symptom-free criteria, whereas the state and feds only require at least 10.
Yeah, and we had a call with Dr. Gounder and Dr. Rubin from LA Department of Public Health, and they work for that acute communicable disease department. And it's not like he came to that decision without thinking about it beforehand. It wasn't an oversight. It was intentional because they still feel like that 10 to 14 day, that space in between those two still offers the ability for somebody to be contagious during that time. So they considered it, but they chose not to do that. And it's within their purview to be able to make those decisions. I will just say, when we look at that stuff, guys, generally those rules and those set of guidance documents are not, the point that we've gotten to now is not based on kind of theory. It's based on actual response. And in Los Angeles County's case, they feel like they have enough practical experience that there's some level of risk in between that 10 and 14-day window. And when they see that, we've got to understand that there's a reason why they chose that. It wasn't not thought out. Now, is it too conservative? I don't know. And and frankly, I don't know that we necessarily, that's a hill to die on with these folks. What our concerns with LA County is the testing and the opening up of admissions, tying that to getting the testing results back in a timely fashion. And those are the things that we can control, I think, and those are the things that we have to make them aware of. But after that conversation with them, I don't see them changing that to go to the CDC guidance or to the CDPH guidance. And it's the same thing with their choice to do surveillance testing of residents. They choose to do surveillance testing of residents where not every county, and certainly the state, does not recommend that. So LA has their own kind of guidance, as do most of the counties in the state. We've got to kind of stick with that and work with them to make sure that we're as efficient as possible doing that, so that you guys aren't sitting there 5 or 6 days after the 14 days and you're still waiting to open up for admissions. Those are the ones that we're really concerned about. Okay, next question, Courtney.
Next question. Do you have any advice for cohorting new admissions from the hospital? If they are quarantined for 14 days, how will they receive therapy? Will they be allowed to leave the room?
Well, I think those other, whatever medical treatments that person needs to do, I think those need to continue. I have not been given any indication that should not continue. We've talked to them, like, how do we do therapy? Are there other places we can do it? Or how do we provide therapy in the rooms? And that was kind of where they came to. We've talked to a number of providers that have creative kind of solutions about providing therapy within the rooms and things like that. But I don't think the expectation from CDPH is that whatever medical care that resident or that patient needs, that we provide that medical care, because that's needed. It's up to us to determine the safest way to do that. I think they'll be somewhat flexible as to how you determine that, but you've got to, think in all of those, what is the process for doing rehab, and who's going to be at risk. So we know the healthcare workers are going to be at risk, so we're going to want them in full PPE, even the therapy person, whoever it is, those folks are wearing full PPE. If I put this person in a separate room, and I'm not doing therapy in their room, I'm doing it somewhere else, whether it's in a therapy room, are we maintaining the distance? Are we in between other folks? Now, we wouldn't want them doing therapy in rooms with positive people, because we don't want them in there with those folks, and we don't want them in there with the folks that are confirmed negative either. So you would be really restricted into who you could possibly do therapy with. But all of those things have to remain. So as you think about whatever your plan is going to be for your individual facility, it's got to factor in all of those things, that the level of safety that you're providing to that resident and to the healthcare workers that deal with that resident is the same as if they were in their room. And so we've got to look at, full PPE. We know that where that space is, we're not going to cohort them with other folks in that area. Outside of that, there's no concrete guidance as to, how you do rehab. This is going to be one of those things where you're going to have to confer with maybe some of your colleagues in other facilities and how they're doing it. I will ask. I think it's a fantastic question, and we don't want these people's health to decline just because they're in our facility and we can't do needed services. So I will ask HSAG on their webinar on Wednesday to address best practices as it relates to doing therapy in the facilities and maintaining the same cohorting and all that stuff. So it's a great question. I don't have a specific answer to give you other than to say, when you do it, and the expectation is that you will continue to do it, is you have to do it in the same manner as which you're providing care now. So next question.
Next question. Do you have any recommendations for evacuating during an earthquake with all of our different COVID cohort groups?
Yeah, and that's a great question. We've got tons of stuff to consider during an evacuation. You know, whenever we talk about evacuation, we're looking at really three, but besides the actual residents, we're looking at three things. We're looking at staff, stuff, right, and a place to put them all. So it's when we think about, you know, kind of how we cohort our buildings, when we triage people for evacuation, we're going to think about it outside of the building. As let's say an earthquake happens, the building's not safe to occupy. When we go out, we have our normal kind of process to set up, you know, kind of an area for triaging, and we can facilitate ambulance transports or any kind of transportation through, and we're picking folks up. As you think about with an earthquake now, we've got three different cohort categories that we're going to have to kind of keep those cohort categories throughout the process of the evacuation. So wherever you're going to stage these folks, they should be staged only with folks in their cohort category, especially the red group for sure. We want them to have clearly identifiable markers, whether it's a triage tag or some visual marker that lets the responders know and lets the healthcare workers know that this person requires full PPE when they're doing the transport. And when we communicate with our county, the MOAC, and we need to tell them, look, I've got 14 COVID positive patients, I've got 14 suspect cases or under quarantine. You basically have got 28 people that require full PPE, and then the remainder of the folks will follow the kind of normal routine. But you've got to think about that and communicate it to the MOAC so that the transport that they send to you guys to help you evacuate, that transport is fully aware of who they're taking. And we've got to work with the MOAC side to talk about you know, where these folks are going to go. And I'll be frank, I don't think there's a really good indication locally, if you had to evacuate right now, where they would put you. And you know, it makes it easier if you've got confirmed negatives. We can probably get those folks in other facilities. It's the folks that were in isolation, and then folks that are confirmed positive. So those are the things that the counties are going to have to work out. And frankly, I'm really concerned that they have not fleshed this out yet. But
Jason,
so as far as so go ahead, Mark, you can add to that.
I want to add nothing about what you've been sharing in terms of the COVID aspects. Certainly that there's a lot there that, you know, we normally don't talk about, but just to really, of course, make the point that hopefully you all understand, you don't evacuate during the shaking, that it's after the shaking stops that you then would exit. And of course, as mentioned earlier, things can be falling off of buildings. But then also during evacuation, at that point, you could have aftershocks. And so it's also looking at whether you're prepared for that, and to be expecting that there could be aftershocks in addition to all that you're trying to manage that could cause further injuries and complications. So, and then for some, even the question of whether you need to evacuate is really an important kind of aspect that requires understanding of the type of building you're in. You know, is it very vulnerable, so that's even more like it old? Is it an older building, and therefore perhaps built at, older buildings were built to earlier building codes, so they're, unless they've been retrofitted, they're not as good as modern buildings. And so that might give you a reason to want to think that maybe it's a good idea to exit. But newer buildings, especially the newer ones that have been built after Northridge they're required to be at a better standard. You may not really need to evacuate unless there are other reasons like power outages and other things that you're trying to deal with. So that all has to be considered in your planning, but whether that's even a required thing that you would want to do. You may cause more issues because you left than if you had just stayed.
Yeah, and that's a great point, Mark, and one we should all think of. We think of evacuation as a viable thing. Not even during COVID, just normally, our number one recommendation and our real guidance to you guys is evacuation is the last resort. It's when the built environment is no longer safe for us to provide care in. And when we think about that, I mentioned OSHPD. OSHPD has a division that works to rapidly identify structures that are either safe or unsafe to be able to occupy in a kind of a healthcare view. If we have an earthquake and you can expect that you will be called by OSHPD to verify, what's going on in your building and how things are going. If you're looking for some education for your physical plant staff, on the cafdisasterprep.com website, there's a video and an in-service for maintenance staff if they're interested in learning on how to review physical plant in the built environment for earthquake damage, kind of visual cues that they should go do, walk around during it or after, not during an earthquake, but after the earthquake. All of those things are designed to help you kind of safely stay in the building. And that's a great kind of reminder, is all of those things that we talked about, the problems with evacuation, we want to avoid that if possible. So great information. Okay, Courtney, do we have any other questions?
Yes, we have 2 more here. Is there any effort to lobby for changing OSHPD regulations to reduce construction costs? Alternatively, is there any effort to lobby for better reimbursement to fund new construction to OSHPD standards?
Yeah, well, the lobbying part about funding, we were actively involved in a piece of legislation that we had a sponsor for, and we had proposed back in January, February of this year. And it would essentially open up, so the state has a program where nonprofits and certain community health organizations can apply for really low interest loans through the state of California. And we have advocated, and we wrote a piece of legislation that if your facility had 70% or more Medicaid or Medi-Cal population, that you would be able to qualify as a public benefit company and thus able to access those funds. But that is the only piece of legislation that we've had even remote success on increasing funding to build new facilities. We may see tons of changes in our industry after this, both from what we expect from the built environment and from how we regulate and operate those things. I think those changes are on the horizon, and the extent of this pandemic and how has it affected everybody, not just the folks in California, everybody in the United States, everybody on planet Earth. Everybody's been impacted by this. So there's going to be, there's tons of pieces of legislation now aimed at skilled nursing facilities. And frankly, we're on the defense now because we just can't imagine more and more being piled onto folks. But we do expect there to be conversations, and maybe they start with more of a residential based model, because that's certainly what everybody wants to go to. But to have a residential based model and expect the same level of infection prevention and infection control as a hospital, the two are somewhat difficult to get to come together. And that's obviously very apparent now. So I think we will see changes to this industry, whether it comes in the form of different types of facilities being built, I don't know. But as for legislation that we've sponsored, that's what we've proposed. And whether that goes forward, I'm doubtful this year. It may be put on suspense and done next year. So next question.
Any guidance on a resident who got admitted at the facility with recurrent positive test results for COVID but is asymptomatic? Should the staff use the N95 when caring for the resident?
Yeah, I mean, how long did they say they had been positive, Courtney?
Did not say, just said recurrent.
Recurrent or persistently positive PCR test. I think if you're meeting the time-based criteria, you're okay, but there are some caveats, like, is this person immunosuppressed? There are some other things that go within that. I don't know if there's a hard and fast rule, but I would say if they're meeting the time-based criteria, including the specifications that they say below, this would be an example of a recurring or a persistently positive individual. And that might be one of the reasons that they've gone away from the test-based criteria to remove transmission-based precautions. So if you're following the time-based criteria, your local health department is also following that time-based criteria, and you've consulted with your medical director that you think this is a result of a persistently positive case rather than somebody that's immunosuppressed and might potentially still be contagious. I think if you do all of those things, that would be somebody that is meant to be removed from transmission-based precautions. So, but I don't know how long they've been persistently positive. Have they been persistently positive for 10 days? Well, that's not very long. So it would depend on how long they've been positive. Next, is there any more questions, Courtney?
Yeah, I think we have time for one more. Will SNFs still need to complete a tabletop exercise this year, and can the pandemic be used as a community-based exercise?
Well, I would highly suggest that everybody that's, and I think it's every facility has activated their emergency plans, and we've all done mitigation plans. It's, certainly for your full-scale exercise, you have checked off that box. Now, there's things from a regulatory environment that you're going to need to do in order to make this activation count towards your exercise, and that's the after action report and the improvement plan. And if you're currently involved in response and you haven't finished that and you're not in recovery yet, you're not going to fill that out until after the response is through. We don't know when they're going to start up the normal surveys again for the EP side, but I would suggest that you're keeping all this documentation, the documentation that you're going to use to build your after action report afterwards. I think that's going to meet the full scale requirement. The tabletop requirement is not going to be met by the current activation. So your second requirement, unless it gets waived by CMS, if this thing goes into next year, that might be something that they waive, but at the moment it's not waived. And the tabletop requirement can be done with a great shakeout. It can be done with your own staff. It does not have to be part of a community-wide tabletop. This is something that you can do at your facility with a little bit of time investment, but much less so than a full scale or a functional exercise. So, but you'll still have to do the tabletop exercise unless it gets waived this year. Next question.
Let's see, we have a comment from Karen Witerinsky, who is our CAF Managed Care Specialist, regarding MOUs. So this is more of a reminder to those on the call with us today to be thinking of putting out those, updating your MOUs with your neighboring SNFs, looking into MOUs with buildings in other counties. Oh, and we do have one more question that I missed a few minutes earlier. Do you have any recommendations for showering residents? This is in reference to both COVID and non-COVID residents. And
I don't know. I think they should still shower. If that was the question, I'm not sure what the like. How do we take them to the shower, and how do we sit with them? I'm not well. Obviously, we're there for the most part. I imagine it's the same as it is for therapy or any other time that person has to come out of their room. We're going to maintain whatever precautions are required by that resident. We're going to ask all the residents, even ask the residents to wear masks when they're not in their room. I mean, we want them to wear masks even if they're in their room, but we know that they're probably just going to take them off anyways. But when they come out of the room, definitely their masks. Maintain the precautions. Outside of that, I don't know that there's anything different that we've been told or any guidance we've been given about specifically as it relates to showers. But if you have a specific question that you want answered, please send it to me, and I'm happy to give it to the folks at the HAI team and ask them on your behalf. So, and one more thing before we finish. If you guys are from Los Angeles County, please hop off our webinar and go to the LA County webinar from Public Health. They're giving it at 2 o'clock right now, and I'm going to hop on it. And they're going to talk about the antigen testing specific to Los Angeles County. So that will be an important one. So with that, I want to thank Mark. Oh, here, let me put on the slide if you guys have questions about CEs, how to get your CEs and things like that. And I want to take this time to thank Mark very much for spending some of his Friday with us and for all the great information. Thank you again, Courtney and Jamie, for pulling this together. And thanks to all of you guys. Hope you have a wonderful weekend. Take care.